and welcome to this talk on really how do we manage significant bone loss in shoulder instability, looking at the Latarjet and alternatives and asking what's the evidence and what's our best option. We're now confronted with a plethora of surgical options when treating instability, from tendon transfers like biceps and the conjoint tendon, through remplissage, through all sorts of bone grafting options. And it starts to get a little bit overwhelming. And the idea here is that we can start to sort of work our way through some of these options and use an evidence-based algorithm to decide how we're going to treat our patients. In this talk, I'm going to look at 4 particular areas of this problem. The first is who should get bone grafting, what the criteria are, what our patient looks like. In the second part, I'll look at the Latarjet procedure, what it is, how it does, and really a discussion also about where it fits in with the arthroscopic Latarjet. I will then look at the different grafting options as alternatives to Latarjet, what the evidence for these is. And the final part of this talk will look at the different fixation techniques, as the whole arena has become more and more complicated over the last few years. So we'll start with what the patient looks like, how we decide which patient is going to get bone grafting. With regards to imaging, there are a number of choices through CT, CT arthrogram, 3D CT, as well as MRI, whether it's MR or MR arthrogram, and then there are these VIBE sequences and more complicated MR sequences. To be honest, it comes down to what's available locally and what your software will do, but really at the moment the gold standard is a 3D reconstruction CT if you can do it. You then have to measure the defect, and there are a number of ways of doing this, with linear measurements, with area measurements, with relative diameter measurements. Again, it's finding what you're comfortable with and what your software will do, but you also have to be aware that there are a number of limitations in terms of either over or underestimating the area and the amount of bone loss. But as long as you're aware of this, then you shouldn't go too far wrong. So who actually gets bone? Well, years ago now, Burkhardt and De Beer recognised that bone loss was an important problem, but initially they measured it at 20 or over 20%. We then became aware of the concept of the on and off track lesion with involvement of the humeral head, and I'm not going to talk about Hill-Sachs defects in this particular talk. More recently, but even this is now 10 years old, we've become aware that the threshold for bone reconstruction is dropping, and the current level is really 13.5%, which if you look at it is about 4 millimeters of bone loss off the anterior glenoid. So once you reach this threshold, you should be looking at some form of bony reconstruction. If we now look at the so-called gold standard, the Latarjet, we'll talk about both the Latarjet procedure and the arthroscopic and do a little bit of comparison of the two with the data that we have. So the Latarjet was first described in 1954, and there have been multiple variations since. And we've talked about congruent arms or non-congruent. We've fixed them with various things, and we'll talk about some of that along the line. But it certainly has proven to be an incredibly reliable operation, but we know that it's a larger incision, that there are issues with the subscapularis down the line, and it does have a complication rate. The arthroscopic Latarjet was first prescribed by Laurent Lafosse back in 2010 as a more minimally invasive alternative to the open Latarjet. It became very popular with a lot of people doing it, but it does seem to have waned. However, there are definitely some potential advantages, and it's opened up a whole new form of surgery. If we look at the biomechanics of the two procedures, there really isn't a lot of difference. Interestingly, in the neutral position, there is increased translation with the arthroscopic technique, but once you come up into the apprehension position, there really isn't any difference. If we compare the two techniques, there have been a couple of meta-analyses, although interestingly, both published at almost the same time, and so probably using a lot of the same data. In this first paper, we'll see that the complication rate of both is pretty high, with the arthroscopic being really quite scarily nearly a quarter of patients, although you do have to remember a lot of these are very minor transient complications. And interestingly, the arthroscopic procedure has a much lower recurrence rate, although a higher revision rate. In this second meta-analysis, published in the same year with roughly the same number of patients, they looked at the results after you got through the learning curve, and what we see here is that recurrence rates, interestingly for the arthroscopic, have gone up, but they're now equivalent, but the complication rate for the arthroscopic has dropped, and they're really pretty well much equivalent. And interestingly, in this meta-analysis, they argued that the operative time was basically the same, which is probably a surprise to most of us. The major place where these two procedures differ is cost. There is no doubt that the arthroscopic procedure is significantly more expensive in terms of equipment that you need just to undertake it. The other question that's often raised is about the learning curve, and there are a couple of papers looking at this. So this is a single centre series where they looked at 30 patients, and after you reached your 15th, your operative time dropped significantly to about an hour and a half with no change in outcomes. In a larger multi-centre series, they discovered that the high volume surgeons reached a time steady state between 30 and 50 cases, and this state was 62 minutes, or a little over an hour, which is really pretty quick. But then probably more relevant to most of us is that their low volume arthroscopic Latarjet surgeons, these are people who did less than 14, didn't reduce their operative time. Now, personally, I don't do more than about 14 Latarjets a year, so I'm probably going to remain in that low volume group. So we do have to be aware of the data and look at, is this the super experts or the average surgeon? So when you look at all the data for the arthroscopic and the open Latarjet, clinically there doesn't appear to be any real difference. The recurrence rate isn't much difference. The complication rate probably isn't significantly different. However, there is no doubt that the arthroscopic has a much longer learning curve, and you probably need to be a pretty high volume Latarjet surgeon to be doing it, and is also significantly more expensive. We'll now look at alternatives to the Latarjet. What other grafting options do we have if we don't want to transfer the coracoid? So these are the most popular. There's the iliac crest, there's allograft, the distal clavicle has been described, the scapular spine has been used, as well as the distal tibia, and we'll look briefly at what the evidence is for all of these. The use of the iliac crest was described independently by both Eden and Hibbinet way before the Latarjet was described. Initially it had no fixation, but it's now been described using a form of sort of wedge, using screws, using sutures and all sorts of other things. What we know with all of these is that the results are good, and we'll talk a little bit about that later on, but union rates are high, well over 90%, and it makes the shoulder stable. It has the theoretical advantage that it doesn't violate the subscapularis and potentially then doesn't damage the lower portion of the subscapularis. It reduces the risk to the axillary nerve. but we'll see some of the evidence potentially against it later on. An alternative to using autologous iliac crest is using allograft. This obviously reduces the local morbidity, which can be pretty bad, but people are worried about union rates and resorption. But the evidence seems to suggest that actually union rates are pretty much the same as iliac crest, and there is no increased rate of graft resorption. The downside, obviously, is it's more expensive. More recently, the use of a fresh distal tibial allograft has been described. The idea of this is that the radius of curvature is matched to that of the glenoid, and you have fresh, viable cartilage, which you don't have with any other technique. The downsides of this are that it has to be sized matched, so you have to wait for the donor. It's fresh, so you have a very narrow window, so your patient has to be ready to go, and you have to be able to provide the operating facilities at short notice, and it's very expensive. It's about £14,000 to put this graft in. Having said that, it does have some good published results, which again are equivalent to the Latarjet, with failure rates of about 1 to 2% and high union rates. So in theory, it's an attractive option. We don't know whether the long-term use of this cartilage is going to make any difference, but theoretically it does. If we look back now at autografts, the use of the distal clavicle has been proposed. We can certainly take the distal clavicle, we do it all the time. It's local to your surgery. There don't seem to be any downsides. So it does appear to be attractive. However, despite a couple of papers being published on it and lots of people talking about it, there are no published clinical results for the use of this technique. Another potential source of autograft, which has been talked about a lot over the last few years, is the scapular spine. Again, it's local, there are no particular downsides to taking it, and there are a couple of published series describing that it works. It should be noted that these series are in subcritical bone loss, so less than that 13.5%, which makes you wonder why they did it in the first place and why they didn't just do a soft tissue repair. The other downside of the scapular spine is it's very variable in its morphology, and therefore if you're going to use it, and it may be appropriate, you have to be very careful about which bit you take. So you have to CT your patient beforehand and you have to measure it up. You can't just help yourself on the spur of the moment. So, as I mentioned previously, the criticism of the non-Latarjet autograft is donor site morbidity, which you could get away with by using an allograft. All of them have the criticism that there is no sling effect, so you're not getting that tensioning of the conjoint tendon as you go into abduction external rotation, and because they're all essentially flat, you're not restoring that glenoid concavity that you may do with a congruent arc Latarjet. However, all of the data says that the outcomes are the same. This is when you look at separate studies and in one very, very good paper where they randomized between the two techniques, there is no difference in outcome. So you might as well do whichever one you prefer. If all that wasn't confusing enough, we're now going to look at all the different fixation techniques you can use once you've decided which graft you're going to put in place. As you can see, there is a wide range. You can use screws. You can use a cerclage technique or some form of suspensory technique, which may represent tightrope or buttons, suture anchors, or even an all suture technique, and we'll look at all of these briefly. For many years, screws have been the gold standard. We all know how they work. We all understand the compression they can give you. And why not stick with what you know? The downside is you have to have these parallel screws, otherwise they don't work. If you get any form of bone failure, the screws can erode the humeral head, as you can see there. And if you have screw breakage, very difficult to get out. More recently, a cerclage technique has been described where you pass this very strong suture tape around the graft and then through the glenoid, and you tie some knots at the back of the glenoid. It's very attractive. You get very, very strong fixation. Some good results have been published. The big downside of this is that you have to make an incision in the back of the shoulder, and you're tying these down, in theory, under the infraspinatus, but in reality you may well be tying them on the infraspinatus, and that clearly probably isn't a very good thing. Having said that, the results are very good. Another alternative is some form of suspensory fixation. This is using either a tight rope or other buttons to compress through the glenoid, through the graft and through the glenoid. Again, you get good compression and some good results have been published. The slight concern about doing this is you are drilling potentially blind through the back of the glenoid. People have also talked about whether you use one button or two buttons. One button potentially being rotationally unstable, but again, some long-term results of using a single button doesn't seem to make any difference. A more recent alternative is the use of suture anchors, and these can either be passed all the way through the glenoid as with the other techniques and out the back, or some people have even fixed them purely on the anterior cortex. Either way, we still seem to be getting union rates of about 90 to 95% with whatever technique you use, and the clinical results all seem to be much the same, with failure rates comfortably under 5% and most of them under about 3%. So what we know, with all the biomechanical and the clinical studies that have been done of all these different fixation types, that actually they get compression and stability that is comparable to traditional screw techniques, and they have the potentially big advantage that they make much smaller holes, and if anything goes wrong and your graft fails, you haven't got all those metalwork problems. You don't have erosion of the head, you don't have to get out broken screws. So probably the future is going to be this, but they do require slightly different techniques that all have to be learned, and some of them are not quite so amenable to being done open. So in summary, the sort of patient that we're talking about is somebody who we've done our imaging on and we know they have more than 13.5% bone loss and we need to put a bone graft into. You can do a traditional Latarjet open. The results are very, very good. Alternatively, you could do this arthroscopically, however, it's much more expensive. It has a long learning curve and probably isn't suitable to the person who's doing less than 15 or 20 Latarjets a year. You may decide that actually you don't need to do the Latarjet because you can use a graft of some sort and the results are comparable. What graft you choose is up to you. Traditionally, we've used iliac crest, and that seems to be the gold standard at the moment. You can use allograft, but it's more expensive, and the quality can be a little bit variable. You can use distal tibia. However, it's difficult to obtain. You've got to get your planning right, and it is very expensive, with at the moment no long-term proven benefit. The other options, the distal clavicle, the scapular spine, we just don't know yet whether they are viable alternatives, and we've got to wait for the work to be done. So once you've decided on your graft, you then have to work out how you're going to fix it. I think the move is probably away from screws because they do create the problems that I've talked about, and we're going to look at some form of suture fixation. Now, whether this is cerclage, where you start at the back and go all the way around, or whether it's something from the front using buttons and anchors and sutures, remains to be seen, and I suspect there's probably a place for all of those. So in answer to the original question, is the Latarjet the gold standard? Well, they're all the gold standard because they all work. And I think it really comes down to the individual, their experience, what equipment they've got, and how they feel about going with the old-fashioned or potentially trying something new. So thank you very much.